Okay, so today I am talking about what not to do for shoulder pain. So last week I talked about what not to do for back pain. As I say in my clinic, by the time people get to me, they've usually failed pretty much everything. I don't take insurance. Most people aren't going out of network until they, are pretty desperate. So most of my patients have failed everything. So I started asking my patients, what they did at their last physical therapist. Normally I don't ask because I don't care. I'm going to put them on my protocols anyways. But I started asking for the purposes of this teaching stuff. And the same things keep coming up. And it didn't work, which is why they're in my clinic. So like last week, I think I talked about like bridges and clams, like bilateral external rotation. I talked about a few things there, bridges. And I don't do that, and I don't see a clinical point to do that. But this week I'm talking about shoulder pain. So let me address like bicipital tendonitis and rotator cuff impingement syndrome, supraspinatus, rotator cuff impingement syndrome, as that's what I see most often in here. Now I do see every once in a while I see somebody that's like dislocated before. I'm not talking about that, okay, in this video. That's a different rehab. But in posterior impingement syndrome is also a slightly different rehab. But I'm talking in this video about bicipital tendonitis and rotator cuff impingement syndrome of the supraspinatus. So I started asking my patients what they did at their last physical therapist, and they would tell me often that they did like rotator cuff strengthening exercises for those two conditions. They had me do like internal rotation. They had me do like scaption or whatever. What else did they say? Eccentric exercises. I see where you're coming from. I don't do that. And the reason why is, to me, the root cause of those issues, I literally can't remember somebody I couldn't get better with those two issues. The root cause of that issue is so much to have to do with posture, okay? And then the way that the humerus sits in the fossa there, okay? So here's the back, okay? Here's the front up here, the acromion, okay? So much of rotator cuff impingement syndrome and bicipital tendonitis is that it's, what I say to my patients is, this is the back here. What I say to my patients is, watch this right here. Watch this bone, right? If I raise my arm up, that clears that hook right there, the acromion process. But when you raise your arm up in an impingement syndrome, at some point it starts to hit, and you get the rotator cuff pinching against the bone right there. And the reason why is because it's too far forward like this in the socket, like that, They have a tight posterior capsule usually, weak parascapular muscles, tight pec muscles. And when that happens, then you start to get this kind of shifting like that, and then it hits right here. So if you were to do internal rotation, I think you would actually make the matter worse with this, because you're creating more of that, okay? We want to create more of this back and down like that. So for that, I strengthen the parascapular muscles, I stretch the posterior capsule, and I do not do anything that would facilitate bringing it forward more, okay? Now when it comes to like supraspinatus strengthening, like scaption, I never do that unless it's like a rehab for like a rotator cuff issue, or like a somebody that dislocates or something like that. But I don't do that for these two issues, the rotator cuff impingement and bicipital tendonitis. And I don't see the clinical point to doing that. Again, it has nothing to do with that. And in fact, if they're impinging and you start doing exercises in an impingement type plane, or go up too high, then you're going to impinge it more and it's going to bother it, So I don't put my patients in pain. I say this over and over again. I don't put people in pain. You put people in pain, this whole thing takes longer. I've been doing this 15 years. I got it down to a science. These protocols I know work at exactly, I've been doing it long enough that I know at this, 5 weeks, boom, it gets better, period, paragraph, But when you start putting people in pain, you start irritating the tissue, and then you're creating fires, and that's why it takes so much longer, So I don't put people in pain. So people do eccentric loading for tendon healing. Like let's say you have bicipital tendonitis, and you're doing like eccentric loading, to help facilitate tissue healing. That irritates it, and I don't do that. If I do that, I quote my patients usually 5 weeks. If I do that, it takes longer than that. I don't see the clinical point of that. Maybe it does, and research show that it gets it better, but you know what else gets it better? To take the strain off the bicep tendon, fix their posture, bring their shoulders back and down, strengthen their parascapular muscles, stretch their chest, okay? You have to fix their posture. And what I show my patients is this. Like I had a guy with bicipital tendonitis the other day, and I said this. I said, go ahead and raise your arm up and try to resist me, right? So his shoulders are forward. I didn't tell him not to, to set their shoulder blades back and down, and I can break them, right? And I say, now pinch your shoulder blades back and down. Now hang, put your arm up. And I try to break them, and I can't. And I'm like, how do you think your bicep tendon feels? Your bicep tendon is irritated because your posture is awful. I don't say awful, but your shoulders are forward like this, and it's coming at an angle like that versus back and down like this. So I find that in order to make the rehab stick, to get better, but also the rehab stick is you have to fix their posture. I'm like militant about people's posture. Shoulders back and down for the rest of your life. I'm up their butts when they come in. If their shoulders are forward, you have to fix that. Because, when that happens, when your shoulders are forward, you're facilitating an impingement syndrome. You're kind of like going like this, and at some point you start to hit here versus back and down, it clears. It doesn't hit versus here, it does. So those are some of the main things that I hear people doing. Most of the time, most people, have good success rates with shoulder issues. It's mainly a postural thing. But in another video, I'll talk about I have a lady that dislocated her shoulder and she wants it stabilized. In that case, I do strengthen all these other muscles and kind of stabilize it that way. Posterior impingement syndrome is a separate rehab. Posterior impingement syndrome, I see a lot of people doing, external rotations, which makes it worse. If you have a posterior impingement syndrome and you're doing external rotation like this, and it's already too far forward in the socket, and at some point it's kind of hitting the rim or the labrum or whatever, then at that point, you're going to create a problem. And that's what these patients tell me. Usually shoulder patients, I don't see, as I said, people come to me when they're desperate, when they've failed everything. I don't take insurance. So the only shoulder patients I see are frozen shoulders, because that hurts like hell, and posterior impingement syndromes. Most of the time they just go to their insurance therapist or whatever. But posterior impingement syndrome, usually orthopedics, I see orthopedic surgeons misdiagnosing this. And the reason why they look at an MRI or something like that and say, oh, you got swelling or you got tendonitis or whatever, but nobody ever checked, hey, when I go like this, when I go like this, it hurts, it like pinches in the back. And what they're talking about is impingement syndrome. What I do to diagnose it, as I've talked about this in another video, is I bring this back in the socket, like I hold it back, the humerus back in the socket, and I have them do the external rotation. Said, does it still pinch right now? No. Okay, well, that's what we need to do. We need to get that back in the socket farther. So I don't do external rotation for that. But most of the time I do external rotation and strengthen the infraspinatus and teres minor for bicipital tendonitis and rotator cuff impingement syndrome. That's really, really, really important. On Instagram, does it apply to brachial plexus injury after an NVA? No, that's a different animal. A brachial plexus injury, I do acupuncture points for that. That's a nervous system type issue. And I try to facilitate the healing process that way. That needs to recover after it's been, stretched out. And I find the best way to do that is actually in my sciatica cervical radic course. I stimulate acupuncture points that connect into that, and it kind of normalizes it. You can actually usually see their strength increase like a full grade after stimulating that circuit. That's on my website. That's the sciatica cervical radiculopathy course. That takes time to heal. I definitely do fix their posture and everything, but a brachial plexus injury is a trauma after an MVA, and you need to let that heal, but I also facilitate it with, like I said, acupuncture points. So that's a different animal, but definitely most people that have shoulder injuries usually have shoulder injuries because they're like this, unless it was trauma. Everybody's posture is awful. just because we sit all day, like most of us are just like this all day long, I always tell my patients, look at a child next time you see a child. Children are like this. My kids have great posture, but life, sitting at computers all day or whatever, driving gets us like this. And if you look at most people, their shoulders are forward, and then we have neck issues, we have shoulder issues, which is, causes a lot of problems. So anyways, let me know if you have any more questions or anything you want me to talk about, but that's what I do for that. And other than that, I'll be teaching in 4 weeks in my clinic. So if you're coming to that course, I will see you there. And then 4 weeks after that, I am teaching in Orlando. And if you're coming to that course, I will see you there. All right? Peace.